Hi everyone, and welcome to today's webinar, Mobile Technology's Growing Role in Inpatient Care Team Collaboration. I'm Mackenzie Bean with Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions. Today's session is also being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Sally Bua is Vice President of Strategy and Innovation and a co-founder of Patient Keeper. Over 22 years, she has held a variety of positions at the company, including in software development, project management, product management, and product marketing. Dr. Chris Mayona serves as Patient Keeper's Chief Medical Officer. Dr. Mayona has devoted much of his career to hospital medicine, both as a practicing physician and executive at provider organizations. Prior to Patient Keeper, Dr. Mayona was a National Medical Director at Team Health and IPC Healthcare, and previously he was in charge of hospital medicine at several multi-site practice groups in the Boston area and Maine. Finally, I'd like to introduce Andrew Robertson. Andrew guides Patient Keeper customers through the technical needs assessment and evaluation process as they plan their purchase of Patient Keeper solutions. Andrew has been with Patient Keeper for 15 years in a variety of technical service and sales support roles. Previously, he was a co-founder and director of technology at ArcStream Solutions and held software consulting and development positions at Fidelity Investments and Navient Technology Solutions. At this time, I'm pleased to turn the floor over to Sally to begin today's presentation.
Good afternoon. I'm Sally Bua, Vice President of Strategy and Innovation at Patient Keeper. I'm here with my colleague, Dr. Chris Mayona, Patient Keeper's CMO and a practicing hospitalist, and we're looking forward to sharing with all of you some insights on the key challenges and opportunities around inpatient care team collaboration and communication, and the important role that mobility can play. We will be joined later in the presentation by our colleague, Andrew Robertson, Senior Director Technical Solutions, as we walk through some specific application scenarios and then answer any questions you may have. Judging from the job titles and organizations I can see are joining us here today, I'm sure you're all well aware that clinical communication platforms continue to evolve, and you won't be surprised to hear that the COVID-19 pandemic has only served to increase the criticality of tight care team communication, as well as highlight the importance of fast and easy access to patient information from both within and beyond the four walls of the hospital. With a plethora of clinical communication offerings out there on the market today, how can you be assured that you're selecting a system that supports best practices? Well, hopefully by the end of today's session, we'll have helped to identify the core attributes to look for to put you and your organization in the best position to drive real outcomes and improve patient satisfaction. But first, let me tell you a little bit about Patient Keeper. Patient Keeper is a market leader in EHR optimization software that focuses on the physician workflow. Our solutions are deployed in over 400 hospitals, and we have over 75,000 active users. For over 20 years, we provided physicians access to patient data on mobile devices, recognizing providers' need to care for their patients anytime, anywhere, not just within the hospital walls. Our customer base is diverse and reflects many different care settings. As a wholly owned subsidiary of HCA Healthcare, we have a large presence across the United States and beyond, and with the resources behind us to continue improving our products to further enhance and improve physician workflows. So what is happening to make the environment for care team solutions so complex? Well, a lot. The core inpatient care team has evolved over time, so that now there are many additional stakeholders in many locations with the added complexity of telemedicine. And then add to the mix the dynamic of COVID-19, and you've also got many more patients to address, often in surges, and pressure to move quickly, efficiently, and effectively to assist each one of them. But instead of talking in the abstract, I'd like to ask my colleague, Dr. Mayona, to address some of the complications of this new world order, both from a communication standpoint and a technology one. Dr. Mayona?
Thank you, Sally, for that setup of what is indeed an increasingly complex and often very time-sensitive environment that today's care team is working in. The medical environment has indeed evolved over the last 20 years. Some of the more significant changes relevant to our discussion today include a transition to value-based care models, an increase in the size and scope of care teams to support the changing care models, and the siloing of care team members for numerous reasons. These factors, in concert with others such as increases in provider-patient census and average census acuity, the emergence of Sentinel EHR offerings, and an increase in documentation and administrative tasks, have placed significant time and administrative pressures on providers and have contributed to the changing environment highlighted in your slides. In my career as a hospitalist and hospital medicine director, I recall, for better or worse, when a care team was composed of a doc, a nurse, and a hospital-based specialist or two. It was certainly a simpler time. What was missing in this evolution, however, was advancement in the tools for data access and communication to support the care teams in this new environment. If you look back at that first slide you showed, Sally, the ecosystem included all the data that was available at the time for a provider to effect care. A doc, a nurse, a hospital-based specialist, and a chart in the Wallaroo. I may be dating myself here with a Wallaroo. I don't know if anybody recalls. We'll pull down right outside the patient's room where you could store the chart for easy access. But I digress. The chart contained all the available labs, studies, and printouts the provider needed. At worst, you had to trek down to the basement to view a film or speak to the radiologist. Now, remember, it was a different time. We are certainly better served today by the clinical tools and the depth and breadth of services we can bring to bear. The salient point is that at the time, the provider had ready access to all the tools in his or her belt required to administer care. But as the environment changed, that comprehensive view was negatively impacted. Data was becoming harder to access in the early EMRs, and the alphanumeric pager wasn't up to the task of keeping care team members connected. Certainly as patient panels grew and physicians became more siloed, perhaps working outside of the house as well as within, it was becoming increasingly difficult to have the time to page and sit by a phone waiting for a return call. For the most part, I think all we wound up doing was playing phone tag. Subsequent initial attempts to utilize the cell phone have for the most part been ineffectual. Any gains are offset by having to navigate complex, non-integrated communications platforms or compromised by the use of unsecure, non-HIPAA compliant SMS text. As a consequence, an argument can be made that both of these factors, challenging data access and inadequate communication solutions, adversely impacted the improved quality the changing environment was designed to cultivate. At present, though, the technology at hand is finally offering solutions to our current challenges. For example, let's look at access to data. Mobility now affords providers access to data wherever and whenever it's needed. This functionality supports workflows that maintain a provider's train of thought. It allows a return to what I refer to as care in the moment. This is a direct correlation between thought and the ability to take action. This is an important point as the needs of the patient or the formulation of a diagnosis or a care plan should not be constrained by the physical location of a computer terminal or its availability. So a couple of use cases here, perhaps. Let's say I need to visualize some labs. I'm walking down the hallway. I've just seen a patient. I am starting to put together the signs and symptoms and connect the dots as I formulate my differential diagnosis or a treatment plan. And as I'm thinking, I realize, oh, it would be really great if I could see a potassium level. Could I see the chest x-ray? And further that thought process, stay in the moment, stay with my train of thought. Well, with a mobile solution, it's right here in the palm of my hand. It's not down the hall at a crowded nurse's station and 20 mouse clicks away. Would it be beneficial to review a med list with the patient? Well, certainly there are opportunities for education around the time of admission when looking at home meds. And again, at the time of discharge, to educate patient or patient's family member on medications to take, side effect profiles and such. This education may also have a positive impact on patient satisfaction, patient compliance, readmission rates, and such. Can I expeditiously address a patient's pain? With mobile CPOE, it's affected at the bedside, in real time, in the moment. Think of what this means when we're out there alleviating suffering. The patient complains of pain, and at the bedside, I can add an NSAID or change the dose of the Percocet or whatever the case may be. But that is going to chip away at the time it takes for that medication to wind up in the patient's system. And what a wonderful thing that is from a patient perspective, but also from a provider's. How about communication? Let's look at the consult process. Think of the challenges that you may have in your institution. I know some of the challenges I faced over the years is trying to determine exactly who is on call for the specialty that I am trying to locate. And how do I reach out to them? In some institutions, a consult has been relegated to a line or two in the EHR. Consult, cardiology, indication, third admission for congestive heart failure in as many months. What happens with that consult if it's placed later in the day and that consultant has already moved on to another facility or is rounding back in their office? Well, perhaps your bylaws state you have 24 hours to complete that consult, which is fine. We're all very busy people. But with a mobile solution, there are some opportunities to shrink this time frame. For example, a mobile platform can integrate with the hospital's call schedule. So I can see exactly who I need to contact. And all the contact information is right there. In fact, integrated into the EHR, I can send a text message directly off to that consultant with a detailed reason as to why I need, in this case, this cardiology consultation. Along with the request, I'm able to send a link to the chart. This allows the consultant to review the patient's record wherever they are, and perhaps whenever is more convenient for them. It's not put upon them to have to wait until tomorrow. So perhaps they can advance care. They can begin to place some orders and move things along, improve the quality of care administered to this patient. Are there updates from the broader care team that require my timely attention? Would simple to effect communication across patients' much larger care team reap the benefit of their involvement? Well, we've created these elaborate care teams. I think Sally had an example here. They don't work if we're not able to communicate with each other. In a mobile world, the updates and the power to reach the team is in my pocket. Think about perhaps some of the challenges you face with effecting timely discharges or having everything coordinated by the multiple team members to occur by the day of discharge so that a patient leaves on time. Length of stay, throughput, boarding in the emergency department may all be positively impacted. The beauty here is that the provider is now in seamless contact with the data and the members of the care team to better affect high quality, efficient, and expedient care. We've taken the foundations of quality care at the bedside, easy access to all available data, simple care team communication, care in the moment, and effectively married them or caught them up to the evolutionary advances in care at our disposal today.
For pre-admission and surgical workflows, we'll see how the clinical communication suite helps bridge communication gaps between providers, inside and outside the hospital, such as surgeons, referring PCPs, and then also it can provide timely automated notifications for pre-surgical and pre-hospital testing. In this first workflow example for pre-admission, we see a referral to a surgeon. I'm going to walk you through what it might look like and how PatientKeeper's clinical communication suite can help with that. Following a referral, a PCP could send a message to the surgeon with important details, including a link to the patient record and a callback number. Tapping the link to the patient record would provide full access to the entire patient record and all clinical information. The PCP could provide some important information about this patient, some background information. The surgeon receives notification and has immediate access to the patient data. The PCP sees when the surgeon has read the message with a double check mark. And then the PCP and the surgeon can communicate important clinical information directly with each other. The surgeon can thank the PCP and provide feedback and improve that communication in the referral culture. The PCP can then follow the patient's progress with the remote clinical viewer and receive updates. Another example is with pre-surgical testing. Now, with elective surgeries opening back up, most patients are required to have a COVID test before the procedure can go forward. If the surgeon orders a COVID test for their patient, we can provide a mobile notification once the test result is available with relevant details available at a glance. The notification is sent through the same messaging infrastructures we saw previously. The ordering provider will receive a push notification as soon as the lab result is available and be able to review that. It won't require any manual intervention, and they'll receive it anytime no matter where they are. They don't have to be logged into the app or at the hospital. Tapping the link will again provide access to the full patient record, and you'll see important details available right there. Dr. Mayona?
Thanks, Andrew. As we take a look at some admission workflows, I'd like to highlight a couple of points. First, effective communication at transitions of care is a key driver of quality. Even rudimentary communication may advance care, limit unnecessary treatment, and prevent harm. And this may be between an ED physician and a hospitalist and a resident, hospitalist and PCP, to give you some examples. A precise patient assignment tool clarifies provider attribution for associated team members to coordinate that efficient, high-quality care. And finally, messaging incorporates vital input from inpatient and outpatient team members, thereby strengthening the continuum of care and PCP relationships. So let's start by taking a look at ED hospitalist communication prior to admission. Again, care team communication begins on admission. In this example, we see an ED physician reaching out to a medicine attending to request admission. Currently, this process is inefficient and timely due to the limits of numeric pages, limited texting options, and providers playing phone tag, as we discussed a little bit earlier. This adversely impacts the quality of care administered. Here, the mobile-enabled ED doc can not only identify and immediately text the attending from within an app, they may also send pertinent information regarding an admission request along with full access to the patient's record. Additionally, more efficient communication lends to improved ED throughput and outcomes. Next, let's take a look at patient assignment. Patient assignment may be effected on the individual level or on the group level. At the group level, a provider going off service may transfer their entire list to a colleague coming on duty. Here we see a use case on an academic service where the ward attendant can assign patients to his or her team. As a hospital medicine group leader, I can certainly attest that the ability to easily navigate patient lists and assign patients gets teams to the floors earlier. Often neglected in the admission and hospital treatment course is the provider who knows the patient best, their PCP. In an environment where hospitals depend on healthy referral networks, PCP relationships are key. Here we see the notification of a PCP that their patient has been admitted. Patient care is further advanced via the ability for the PCP and hospital attending to communicate. Andrew, back to you.
Thank you, Dr. Mayona. So we've walked you through a little bit of pre-admission and admission workflows. Let's take a look now at how Patient Keeper's Clinical Communication Suite can help in the facility. For in-facility workflows, the Communication Suite facilitates communication across service lines over an entire hospitalization. Remote consults are made possible with mobile clinical viewing access and the ability to receive messages and notifications outside the hospital, anytime, anywhere, and without delay. And as with pre-surgical workflows, automated notifications for lab or test results are crucial for certain workflows and can be delivered to the physician's mobile device without any delay or manual intervention. In one scenario, we see an example of care team communication for a patient. A nurse and attending provider may communicate using messaging regarding patient care questions and requests. The nurse and attending provider may change from day to day, but you'll always be able to find out who the right person is through the patient care team integration within the app. The attending and nurse can also communicate with ancillary care team members, case management, nutritionists, the lab, etc. As we saw earlier, communication is critical within the context of a specific patient. Patient is included in the message, and then you see the header at the top and a footer at the bottom indicating that any message is about that patient. This allows one-click access to the full patient record and also provides a consolidated view of any messages sent between any users about the specific patient. Another example that you see frequently is for consult request. Consult requests can be sent through messaging to the appropriate provider from the integrated on-call schedule. It all starts out with finding who the right person is to send the message to. The consulting physician, no matter where they are, can receive remote push notifications that show rich information that helps them prioritize their response. This will include the physician requesting the consult. It will include the specialty and could even include the first few letters of the patient's name. They can just glance at their phone or even their watch and make a quick decision on whether they need to respond to the message right away. The message also includes a link to the patient, which, as we've said, allows immediate mobile access to the full patient record and could even allow them to perform the consult remotely. They can add the patient directly to their own consults patient list or any other list they choose from there, and photos could also be included in the message to provide additional context. There are tools available for the consulting physician to manage their pending consults and to take action. They could send a message back to the ordering provider with a link to the patient and a reference to the consult with a question. They could accept or decline the consult or forward to another person or group. The attending physician sees when the consulting physician has read the consult request message and gets a response back to close the loop. As we've showed with pre-surgical workflows, critical lab notifications could be sent. This example shows the COVID test again, but any sort of lab result could be set up to send out automated notification to the ordering physician as soon as the result is available without requiring any sort of manual intervention. The mobile notification shows part of the patient name, the test name, and the criticality. And the notification message shows the full test result with a link to the full patient record. That allows timely notification for critical information so the physician can see that right away. And back to Dr. Mayona.
Thanks again, Andrew. From a discharge process perspective, effective communication between care team members is essentially to delivering quality care. In a value-based marketplace, teamwork is critical to financial success. Messaging provides a simple modality for individuals as well as teams to communicate within their normal workflows, facilitating more comprehensive patient care. From a nursing perspective, messaging allows identification of the responsible physician, notification of essential data, confirmation of data receipt, and a modality of communication that respects both parties' workflow. Messaging facilitates HIPAA-compliant communication to engage office personnel and schedule follow-up appointments at the point of service and prior to the onslaught of activity at the time of discharge. Data in messages on a unique patient from disparate senders may be consolidated for viewing in a patient communication module. Messaging facilitates vital input from outpatient team members, thereby strengthening the continuum of care and PCP relationships. So let's start by taking a look at care team coordination. Coordination of care between members of a patient's care team during hospitalization and at discharge are key factors in affecting safe and timely discharges. Here, as an attending messages their intent to discharge a patient the following day, the members of the care team are provided the advance notice necessary to plan accordingly. The case management requires a day to set up a VNA. Nutrition provides input on diet at the time of discharge. Cardiology requests case management schedule a follow-up visit in the office. Addressing the needs of a patient at discharge prior to the day of actual discharge lends to improved throughput, decreased length of stay, and decreased readmission potential. Now let's take a look at office communication. In the prior workflow, we saw cardiology requesting case management schedule and outpatient follow-up. Here we see the message from case management to the cardiologist's office, which includes a link to the entire patient encounter and the necessary demographic information for any pre-approval and contact information. The ability to schedule an appointment at the point of care also increases the likelihood that the appointment will be made. PCP notification is also important. Here we see PCP notification that contains a link to the patient's record. In some locales, PCP notification falls short, with concerns raised that a PCP was perhaps not aware of the events occurring during hospitalization, the discharge diagnosis, the changes to a medication regimen, the pertinent studies that require follow-up, and when that follow-up is expected to occur. A stalwart of PCP relationships is keeping the PCP well informed prior to the patient's return to their office. Here this is effected effortlessly by the attending, alerting the PCP to review the discharge summary while providing the PCP with a vehicle to reach out if any questions. This simple communication has the potential to improve quality and positively affect readmission as well as post-discharge morbidity and mortality. Last, let's take a look at documentation. There are several note types that lend well to documentation on the mobile platform. The value proposition in these supplemental notes is that there are certain note types that require immediate or urgent documentation to update the care team on events that perhaps transpired following daily rounds or in the evening or overnight hours. So some examples here may be a progress note addendum or procedure notes, urgent documentation such as that following rapid response codes or even psychiatric evaluation. And then finally, and unfortunately in this day and age, there's some untraditional documentation such as COVID triage notes that may take place in a tent out behind the hospital. I'll close with a little environmental perspective. The care team environment has certainly evolved. Teams are larger and more dynamic. In the age of COVID, they continue to evolve, now incorporating telemedicine and temporary triage units. In the face of this active evolution, care team collaboration has never been more important, and access to the data as well as simple, effective communication tools is key to this success. Clinicians are more mobile and must be provided with the tools to facilitate care in the moment.
Wonderful. Well, Sally, Dr. Mayona, Andrew, first off, I just want to say thank you for such a great presentation and all of those insights. We'll now go ahead and start today's question and answer session. Any audience members out there, if you have any questions that you'd like to ask our panelists, feel free to do so now by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for. So it looks like we already have a few great questions rolling in. The first is, does the app integrate with any EMR, or does it also integrate with ancillary systems?
Andrew, can you go ahead and answer? There you go.
A patient keeper can indeed link with other applications beyond the EMR, including labs, PACS, practice systems, or HIEs. Patient keeper can integrate to most popular EHRs as well.
Perfect. Thanks for clarifying that, Andrew. We have another question here who's asking, this audience member is asking, can community PCPs have access to the patient record, and how do you facilitate this connectivity?
Andrew, how about that one? I think you were looking at a second question very similar to that.
Yes. Community PCPs absolutely can have access to the patient record. We can facilitate this by providing the community affiliate PCPs access to patient keeper's desktop or mobile application, and we can share data using industry standard interfaces or APIs.
Perfect. Thanks again for weighing in there. This next question is, can secure texting apps like TigerText be integrated with EHR systems to accomplish what you're describing?
Sure, I'll take that one. It does definitely depend on the application and the EHR. Some applications like Patient Keeper are integrated directly with the EHRs, and they'll give access to the patient data from within the mobile application. Other solutions are lightly integrated and only allow the manual sharing of data, for example, by cutting and pasting or sending links for access. Ideally, what you want is your providers to have a tightly integrated solution that will give the full access to the EHR data within the mobile app, allowing for the embedding of that data directly into the messages, into team chats, and for sharing photos or other information within the EHR environment, and have that information embedded directly back into the EHR as appropriate.
Wonderful. Appreciate you weighing in there, Sally. Thank you. Another audience member is asking, how are patient records from a hospital EHR shared with extended care team members outside the hospital who don't use that EHR?
So, Andrew, I think you kind of answered that one already. You want to pull that one out a little bit and give some more info?
Absolutely. As I mentioned earlier, Patient Keeper does facilitate sharing data across care teams, including affiliate or PCP providers outside of the hospital. So these may be users who aren't actually using the EHR. Patient Keeper can allow those users access to that shared data, and then, as I mentioned, data can be further shared to non-EHR applications using those standard interfaces.
Great, thanks, Andrew. Appreciate you expanding on that question. Another audience member is asking, is the creation of an app underway?
I assume by that you mean, is this application in process or being created? Certainly for Patient Keeper, our application and our software has been out and available and in use by physicians for many years across various EMRs. So I'm assuming that was the question. If that doesn't, please ask again with more detail.
Fantastic. Thanks, Sally. We have another audience member here who is asking, is video chat a viable substitute for the impromptu face-to-face conversations providers used to have in the hospital?
Chris, as a physician, I think you're best poised to answer that one.
Sure, I'll grab that one. Thank you, Sally. Well, my opinion is nothing would replace face-to-face communication, but in instances where face-to-face is not available, which, given our presentation, unfortunately, is more and more frequently, then having a video chat capability is certainly the next best alternative. And, one of the reasons may be that just having the ability to see the party that you're communicating with. I think we've lost a lot as we've been siloed over the years. Having the ability to pick up those visual cues or to associate a person instead of a faceless name or number on the other end of a line, I think helps build relationships and certainly optimizes the care that can be subsequently delivered.
Yeah, I think that's a great point to add, Dr. Maiona, so appreciate your insights there. This next question is from an audience member who's asking, are there opportunities for sign out in a mobile environment?
Well, that one sounds like me as well. Certainly so. And, sign out, I think, is one of those areas we were discussing how we've had some challenges with evolution. I think sign out was one of those areas that got left behind. So when you look at the prior state, we had the ability to find everybody within our ecosystem to sign out to at the end of a day. But we've lost it along the way. And as a result, what's happened? I think we have created an opportunity for adverse events and harm due to communication errors or omissions. So certainly during the course of the day, having something that you could contribute to for sign out that makes the process simpler, makes it more convenient so that perhaps you're not leaving this to the end of the day when you're trying to get out of the house. And of course, when we look at sign out, we can look at the various ways to structure this because there isn't just one opportunity, right? You might want a simple text box. Jot down a couple of notes for the next provider. You may want something more structured. If you look at some of the opportunities or the recommendations with sign out, the iPass modality would lend very well to our solution. And also the prior question about video chat, because if you're familiar with iPass, that last S is synthesis, and it's the ability of two parties to have preferably a face-to-face communication so that one can ask questions about the sign-out and the other can gain feedback.
Wonderful. Thank you again for weighing in there, Dr. Maiona. The next question is, what IT tools are clinicians currently using?
So Andrew, why don't you take care of that and answer it based on our IT overlay?
Sure. So Patient Keeper supports a full overlay of IT systems for providers. So we allow a physician to spend their entire day in Patient Keeper and fill their entire IT workflow within PK. So on a full deployment, this would include medication reconciliation, clinical documentation, CPOE, as well as the clinical communication suite. For applications where Patient Keeper doesn't fully overlay those solutions, things like a PAC system, for example, we will have thoughtful links that include patient identification and context from both Patient Keeper's desktop and mobile applications to those third-party apps.
Great, thank you for that overview, Andrew. Dr. Maiona, let me turn to you for this next question. Do you incorporate signed consent forms in the workflow?
Certainly so, because it's much more convenient to be able to address orders, consent forms and such in the moment over the course of the day than putting these things off and potentially delaying.
I'm so sorry, Dr. Iona. It sounds like you might have cut out for a second. Would you mind repeating that?
I'm terribly sorry. Let me try that. The short answer is yes, we do.
Perfect. Short and sweet. Wonderful. Well, that is all the time that we have left for today. Sally, Dr. Iona, Andrew, I just want to say thank you again for such a great presentation and great insights in the Q&A. And thank you to Patient Keeper for sponsoring today's webinar. I hope everyone has a great rest of their day, and we look forward to having you join us for future webinars.